This conference will now be recorded.
పర్లేదు సార్ 2 మినిట్స్లో వచ్చేస్తారు సార్.
Good morning, everyone. I am Dr. Nikhil. Can you all hear me?
Yes, sir.
Okay, I am from the Department of Radiology, and we'll be talking about acute radiological emergencies. We'll see what cases we'll encounter in our emergency department and how they will appear on radiological imaging. First of all, we'll deal with cerebrovascular accidents, or what we call strokes. They can be either ischemic or hemorrhagic. And in a ischemic stroke, we'll image the patient using either a CT scan or an MRI, depending on the compliance of the patient, or depending on the evaluation by the clinician. They will either advise a CT or an MRI. And this, what we see here, is the MRI scan of a patient with presenting with an ischemic stroke. That is, his symptoms were loss of consciousness, sudden loss of consciousness, with no history of previous trauma or anything. He was a known hypertensive. So on MR imaging, the basic sequence you see for an to identify an infarct is the diffusion sequence, which is shown here. The image on the right is the diffusion sequence, and on the left is the diffusion sequence. On the right is the ADC, or the which is the apparent diffusion coefficient. These two images should be studied side by side to identify an infarct. So when the MRI is done and you want to know whether the patient has an infarct or any other pathology, you can just ask the technician to please show the diffusion sequence and ADC sequence, and he'll scroll through the images. And if you notice any bright structure, bright area within the brain, usually it should be low intensity signal throughout the brain in the diffusion sequence. But if you see any high intensity or bright signal in any structure of the brain, and in the same region, the ADC image also should show dark signal. So it should show bright signal on diffusion and a dark signal on ADC. So if you see this picture, you can say that this patient is having an acute infarct, and you can promptly notify your attending physician that this patient is having an infarct, and they will go for either thrombolysis or further treatment. And since there are two types of CVA, that is, there are ischemic or hemorrhagic, we need to differentiate between these two. And for hemorrhagic stroke, CT is more sensitive, where the blood products within the brain appear as hyperdense or bright. MRI can also be used to identify blood products, that is hemorrhage, but we need to take GRE sequences, that is a special sequence. And patients usually presenting with hemorrhagic strokes are usually not so compliant, and they might be moving and might not be. And performing MRI scan will take more time, and if we need a fast diagnosis and fast scan, we go for a CT, and we can rule out hemorrhage in CT as it is easily identified as a hyperdense structure, hyperdense attenuation within the brain, which is a bright structure. And this is a CT scan of a brain in a patient with an ischemic stroke, not a hemorrhagic stroke, where compared to the right side, the left frontal lobe is showing reduced attenuation. That is, compared to this side, this is appearing a little dark. So this is in CT, the ischemic stroke appears as a hypodense structure or a darker structure, relatively darker structure. And if the patient presents very early, that is in a hyperacute setting, that is within 3 to 4 hours, it is very hard to identify on a CT scan. But on a diffusion scan in an MRI, it is easily identifiable. And as such, in a hyperacute or acute setting, it is more preferable to go for a brain MRI than a CT to identify an ischemic stroke. And coming to brain hemorrhages, this is a CT scan of a patient showing two types of hemorrhages. One is an extradural hemorrhage, and the other is a subdural hemorrhage. And these have a classic appearances, which is either a banana shape, which is a subdural hemorrhage, or a lemon shape, which is an extradural hemorrhage. As we can see, the blood products on a CT appear quite bright and can be easily distinguishable. So coming to what are these extradural and subdural hemorrhages? Coming to an extradural hemorrhage, this is the accumulation of blood outside the dura mater. The blood accumulates within outside the dura mater and within the inner table of the skull, and it is usually due to accidental injury. And you should look for any adjacent adjoining bone fractures when you see an EDH. And most common artery involved in the formation of an extradural hemorrhage is the middle meningeal artery. And since the dura is present medial to the hemorrhage, it forms a lentiform shape, that is a lens shaped structure, and it does not cross the suture lines. That is it is confined to the any one of the bones, that is either a parietal bone, and it won't cross the sutures between the skull bones. If you see a hyperdense structure crossing the sutures, that is this you see the subdural hemorrhage, which is crossing the which is covering both the frontal and parietal and temporal and occipital lobes, occipital bones. So as to say, it is crossing the sutures, but in an extradural hemorrhage, it is limited to one bone and within the sutures of that bone. Coming to subdural hemorrhage, it is present within the beneath the dura and is usually not accidental, but can also present during accident as a countercoup injury. It is due to the rupture of bridging veins and dural venous sinuses due to shearing forces. These subdural hemorrhages are crescentic in shape and they cross sutures. Here we can see a subdural hemorrhage on the right side of the brain, right side of the head, involving the frontal, parietal, and the parietal lobes. Coming to the next emergency case we commonly see in the casualty is the foreign body ingestion or inhalation. And as such, the foreign body can either be present in the trachea or the esophagus. And if we know what the foreign body is, we can identify it based on the radiographs. That is, one is the AP, that is anterior posterior, and the lateral radiograph. For example, let's take the patient has ingested a coin. We want to know whether it is within the trachea or the esophagus. We take a AP radiograph, and if the coin is the long diameter of the coin is in the AP diameter, that is, since the trachea is also long in the AP diameter rather than transverse due to its cartilaginous rings, the coin will appear to be standing on its end. And on the lateral radiograph, we can see it and see it end face as a rounded structure. And as such, we can confirm that it is in the trachea. And if the coin is in the esophagus, since the esophagus is a collapsed structure and it does not have any supporting cartilage rings or anything, the esophagus normally is collapsed, and as such, the coin will remain flat, and it can be seen end face in the AP radiographs. And on the lateral radiographs, we can see it from the side. Another emergency which we can easily miss is an aneurysm, because the patient presents with either chest or abdominal pain, which we might think of it as an myocardial infarction or a simple gastritis. And as such, simple radiograph can be used to identify large aneurysms. Here in this PA radiograph, we can see there is a large aortic aneurysm, which is seen as an radio density noted in the left upper zone of the lung. It seems to, and there is loss of we can't see the aortic knuckle separately. As such, we can identify that this radio density is arising from the aorta, and this is an aortic aneurysm. This is a normal radiograph, and this is the abnormal one with the aortic aneurysm. Usually we see the aortic knuckle as such with the descending aorta and the left heart border as such. And this is the left heart border, and this is the enlarged or this is the aortic arch aneurysm. And coming to another common presentation we see commonly in our emergency is the intestinal obstruction, presenting with abdominal pain and inability to pass flatus or and presenting with constipation. And usually we take an erect abdomen radiograph. And in case of an intestinal obstruction, we see multiple dilated bowel loops with air fluid levels. Multiple air fluid levels. This, when you see such dilated bowel loops with multiple air fluid levels, you can suspect and also confirm intestinal obstruction. So how to say if it is a normal gas in the abdomen or if it is an abnormal gas. So each organ has a normal and an abnormal air and gas and air fluid levels. In the stomach, it is normal to have air fluid levels, and so also in small bowel. But if there are more than 3 to 4 loops, small bowel loops visible with air fluid levels, we can suspect small bowel obstruction. And in the large bowel, we can you should only be visualizing air, but if you see any air fluid levels, you have to strongly suspect intestinal obstruction. And how do we identify small or large bowels on the radiographs? The large bowel is usually, as we know, placed peripherally within the abdomen, and small bowels are located centrally. So if you see any bowel shadows close to the spine, we can be sure that this is a small bowel which is placed centrally. And as we all also know, the small bowels have mucosal folds which are called volvulae conventus, and we can also see them in a dilated small bowel loops. And in case of large bowel, we see hostrations which are not complete. These in case of small bowel, the volvular contents, these are complete. These are incomplete markings, radio markings, dense markings within the bowel, and the bowels are seen arranged peripherally in the abdomen. And then in case of intestinal obstruction, we can also suspect intestinal perforations. And in that case, the telltale sign for an intestinal perforation is pneumoperitoneum. And what we usually see for in an erect abdomen X-ray is the air under the diaphragm in case of a pneumoperitoneum. But if the extraluminal air, that is the air outside the intestine, is very small to accumulate under the diaphragms, we can see we can use what is the regular sign. This is not seen in an erect abdomen film, but in a supine film where the patient lies down on the table and we take a AP radiograph, anterior posterior X-ray, where we can see both the outer and inner layers of the bowel. Usually we can only see the inner layer of the bowel, but if we can observe both the layers of the bowel, that is outer and inner, which is due to the presence of air outside the bowel, which is making us which is enabling us to observe both the layers of the bowel. This we call as the regular sign. See, we can see this is the intraluminal layer and the extraluminal layer, which is enabling us to visualize both the layers of the bowel. This is a regular sign. This we see commonly in the supine film. And another sign is the Doge's cap or Morrison's pouch free gas. What is a Morrison's pouch? This is the hepatorenal pouch, or the potential space which is present in between the right kidney and the liver. And this is a very important space, as in case of pneumoperitoneum, we can see accumulation of air within the space, or in case of ascites or an hemoperitoneum, we can see fluid accumulating, small amounts of fluid which accumulates in this space. So this is, we can see this sign also in the supine film, that is the patient lies down and we take an X-ray in the anterior posterior direction. And usually this Dodge's cap or Morrison's pouch free gas sign is seen as a triangular shaped radiolucency just inferior to the liver and above the renal shadow. It will have a sharp lower lateral corner and a concave lateral corner due to the contour of the liver. It is positioned usually inferior to the 11th rib and position superior to the kidney. And then in case of a large amount of free air, we can see the falciform ligament sign. See in this radiograph, we can see there is air underneath the diaphragm, and also we can see the regular sign, which is outlining the bowels and enabling us to see the entirety of the wall. And we can and in such cases, we can also see the falciform ligament, which connects the anterior abdominal wall to the liver. It extends inferiorly beyond the liver and becomes the round ligament. In pneumoperitoneum, it becomes outlined with air and is visible. And we can also see this in the lateral radiographs. And on the football sign, this is usually we see in neonates with massive air-filled peritoneum, pneumoperitoneum, where this abdominal structures take in the form of a football. And this is another sign which we can also see in even if we don't suspect the pneumoperitoneum and take erect abdomen film, we can see this on a chest X-ray. As we can see, usually we do not observe the entirety of the diaphragm across the midline, but if we can see the abdomen diaphragm extending from the right to the left and across the midline, then this is an indicator of massive pneumoperitoneum, which is the air under the diaphragm. And this is the continuous diaphragm sign, which is also pathognomic of pneumoperitoneum. And if the air is not present entirely along the entire length of the diaphragm, we can see a cupola sign, which is just the accumulation of air just under the central tendon of the diaphragm and not under the domes. And there is a triangle sign, which is accumulation of gas between two to three adjacent bowels, or the adjacent bowel and the flank. This is the bowel loops and the flank, and we can see a small triangle area of air. We can also see this as air trapped between 2 to 3 bowel loops. And ligamentum teres sign, this is the accumulation of air around the fissure for the ligamentum teres. It is seen as a linear density running along the inferior edge of the liver. And coming to the next entity, that is the acute appendicitis. Usually this can be diagnosed clinically due to the clinical findings, which is the tenderness, pain and tenderness in the right lower quadrant, and from the clinical history of the patient. And usually, if the clinician has a doubt whether this is acute appendicitis, is an appendicitis or any other abdominal pathology, or if it is not, if the patient did not present acutely, and the clinician could not elicit the signs, the clinician usually advises an ultrasound, abdominal ultrasound. And in that, this is how a normal appendix looks like in the ultrasound. which is a blind ending sac, and usually shows all the 3 layers of the ball. And this is in the longitudinal section, and this is in the axial cross section. Usually the appendix should not be more than 6 millimeters in diameter, and there should be no collections around it or any other inflammatory changes. So what changes do we see in ultrasound of an acute appendicitis? Usually we can see when we are even doing the ultrasound, we can elicit the tenderness in the right lower quadrant, and lab parameters we see elevated white blood cell counts. And first we should identify the appendix, which will be blind ended, and it will not be continuing when we try to project the appendix. And if it is continuing, we should it is usually the one of the small ball loops, and it is usually blind ended. It should not be compressible. That is, when we apply pressure with our ultrasound probe, it should not collapse, and we should not visualize any peristalsis within the tube, and it should show all the normal gut signature, that is all the layers of the bowel. And we can also trace it back and visualize it arising from the base of the cecum, and it should not be more than 6 millimeters, that is in a normal appendix. And in appendicitis, after we visualize and identify that this is the appendix, and if the diameter of the appendix is more than 6 millimeters, and there is surrounding fluid accumulation or any appendicolith, that is any stones or anything within the fecoliths within the appendix, and any pericecal collections or any fat inflammation around the appendix as such. Here we can see the blind ending loop with the gut signature, which is also dilated, and the diameter of the appendix here is more than 6 centimeters, measuring around 7 to 8 millimeters, and there is adjacent fluid collection, and this is a case of this is how we can identify the case of acute appendicitis. Another another emergency is ovarian torsion, which presents with abdominal pain. And we usually first line we perform the ultrasound. There we can see an enlarged ovary with enlarged peripheral follicles, and on when we see in color Doppler, there won't be much blood flow to the ovary, or there may be reduced flow in the color Doppler ultrasound. And this is a case where we see enlarged ovary and enlarged follicles within the ovary, and we followed and after follow-up of this case, the size of the ovary has increased doubled, and this is a case of ovarian torsion. It should be identified and should be operated immediately. And similarly, we have acute scrotum, which and most common for these acute scrotum is the testicular torsion. As such, which we need to identify this, as we can salvage the testis and can save the organ. Usually this is the normal appearance of the testis on the left side, right side, where after we see in color Doppler, here we can see blood flow within the right testis, which is a normal, and within the left we do not see any blood flow, which is this is how we can say there is a torsion and cessation of blood to the testis. And this is another image with acute epididymitis, where we can see increased size of the epididymis and showing increased vascularity with color Doppler imaging. And this is another important emergency, which is ectopic pregnancy, where the patient deteriorates very fast and needs to be operated immediately and identified. Here the woman presents with a positive pregnancy test or a history suggestive of ectopic pregnancy, which is a missed period, pain, unprotected intercourse, and it is critical to identify the presence and location of the gestation sac. And this is a transvaginal ultrasound in a case of ruptured ectopic pregnancy with hemoperitoneum. Here the patient presented with right lower quadrant pain at 6 weeks gestation. This is a transvaginal ultrasound showing this is the uterus, and there is an echogenic material within the endometrial cavity, but no gestational sac. And here we see hypoechoic structure posterior to the uterus. This is the blood clot which is seen around the uterus in the axial section. In the axial section, we can also see a complex right adnexal mass and with a hypoechoic round structure which seems to be a sac. This is the ectopic pregnancy which is seen within the right adnexa. And another emergency is the acute DVT or deep vein thrombosis. Here the patient presents with uh, pain and swelling of the lower limbs or just pain in the lower limbs with either cyanosis or swelling. Here the clinician advises arterial or venous Doppler of the lower limb. Here on the arterial Doppler, here we see color filling within the artery, but not within the adjacent vein. And the diameter of the vein is increased, and there is an echogenic material within the vein, which is suggestive of a clot or a thrombus. And similarly, in this structure, we can see there is collaterals arising from this vein with the normal lumen. There is no color filling within the lumen of the vein, which is showing echogenic material, that is the thrombus. We need to identify DVT and report it to the clinician so they can plan for thrombolysis and can save the limb. Thank you.